Hello guys, welcome to my channel. Today we are going to study about fallopian tube. So it is originated from Mullerian duct. So it has a mesodermal origin and its length is 10 centimeter, that is 4 inches. So it has 4 parts from medial to lateral. We can see this is a fallopian tube. It is divided into 4 parts. The medial most, this is the interstitium or the intramural part. The next is the isthmus, and the next is the ampulla, and the fourth is the infundi. The next part is the infundibulum. So now we are going to study in detail about these 4 parts. So in this is 4 inches as we have studied. So the first part, that is the interstitium or the intramural part, it is half inches long and it is a narrowest part. As it has circular muscles, it is also known as anatomical sphincter. And the next part, that is the isthmus, it is the second narrowest part after the interstitium, and it is also known as physiological sphincter because the product of conception that moves from the ampulla to the isthmus. So it is the widest part of the fallopian tube. It moves to a narrower part. So this isthmus is known as the physiological sphincter, and this interstitium, it has circular muscles, so it is known as anatomical sphincter. And this isthmus is 1 inches long, and the ampulla, which is the longest and the widest part, so it is 2 inches long, and it is a site of fertilization and ectopic pregnancy. And the maximum mucosal fold that is present in the ampulla, and that is known as plicae. And also this isthmus, it is a site of female sterilization, the tubal ligation that is done in the isthmus. Okay, and the next part, that is the infundibulum, it is half inches long and it is surrounded by a number of fimbriae. So these are the fimbriae that is present in the infundibulum, and one of them is longer, and that is known as ovarian fimbriae, that is attached to the outer pole of the ovary. And this is about the parts and its details. Next we are going to study about the histology. So in histology, it has 3 layers. The outermost layer is a serous layer, and the middle layer is a muscular layer. So it has 2 layers of muscles, inner circular and outer longitudinal. And the mucous membrane, that is here the lining epithelium is simple columnar epithelium, which is partly ciliated and no submucosa or any glands present. And this fallopian tube, it is lined by PEG cells. And the most common cancer that happens here is adenocarcinoma. So how we know what cancer will occur in what? Depending upon the epithelium. So if the epithelium, if it is squamous epithelium, then squamous cell carcinoma will happen. If it is cuboidal epithelium or columnar epithelium, then adenocarcinoma will happen. So depending upon the epithelium, the cancer will be there. And the function of fallopian tube, what is that? Transport of gametes, then facilitate fertilization and survival of zygote through its secretions. Then we move to the blood supply of the fallopian tube. It has an arterial supply and a venous drainage. The arterial supply, the medial two-third, it is supplied by uterine artery, as the uterine artery mainly supplies to the uterus, but it also supplies to the medial two-third of the fallopian tube. And the lateral one-third is supplied by ovarian artery, as we can see here. So this is the ovary and this is supplied by ovarian artery. So the lateral one-third is also supplied by the ovarian artery. And the venous drainage is through the pampiniform plexus. It drains into the ovarian vein, and the nerve supply is through T11, 12 and L1. The lymphatic drainage, the major part is drained into para-aortic lymph node, and the intramural or interstitial part, the first part, the medialmost part, it is drains into superficial inguinal lymph node. And some miscellaneous points about fallopian tube is the fallopian tube along with ovary is known as adnexa. Genital TB most commonly affects the fallopian tube, the ampulla, and it can lead to bilateral cornual block. And the gonococcal infection, it also affects the fallopian tube and it leads to fimbrial block. An investigation of choice for tubal patency is hysterosalpingography to know whether the tube is patent or not. And the site for tubal ligation, as we have studied earlier, it is at the isthmus by laparoscopic method, and if we are doing a hysteroscopic method, then at interstitium by a device that is known as E-Sure.